This is Heart Rhythm TV. I'm Clinton Thurber. Welcome to Breaking News. The publication of Castle AF and Cabana ushered in what most of us consider the modern era of AF ablation clinical trials. The data has strengthened with the release of others like East AFnet 4 and Early AF, ultimately culminating in much anticipated AF guideline updates we've seen out of both the US and Europe. Despite this deluge of high-quality data, critiques from both outside electrophysiology and even within the field have called for sham ablation trials, especially on the heels of the Orbita trials published by our interventional colleagues. Today, I'm pleased to be joined by the investigators of SHAM-PVI. First author, Dr. Rajdip Dulai from Eastbourne General Hospital in Sussex and Essex Cardiothoracic Center, and senior author, Dr. Veasey from Eastbourne General Hospital in Sussex. So SHAM-PVI was presented at ESC Congress 2024, the scientific sessions for the European Society of Cardiology. Welcome, gentlemen. Thank you for joining me.
Good morning. Thank you. Good morning. Thanks for inviting us.
Of course. Happy to have you. So I'd like to start off by kind of getting into the conception of the idea for the study. Every trial, every study in medicine, period, starts with ideas and discussions among colleagues, often seeing a need based on our own procedural experience. Tell me what that was like, what those early conversations consisted of.
So the initial, as you already said, there's been concern that pulmonary vein isolation exhibits a placebo effect, and there's been sham-controlled trials in other areas of cardiology, namely the Orbita studies and simplistic hypertension-free study, and there's been a call for testing pulmonary vein isolation versus the sham procedure. So we initially thought about doing this study in 2019, and that's when we started to get together as a research group and started to design the study. So the study was a prospective, dual-center, double-blind, sham-controlled study performed at two centres in the UK, namely Eastbourne District General Hospital and the Essex Cardiothoracic Centre. We recruited patients with paroxysmal or persistent atrial fibrillation, despite at least one antiarrhythmic or beta blocker. 126 patients were randomized, 64 to ablation and 62 to sham intervention. Broadly, the two groups were similar in their characteristics. The majority were male and had persistent atrial fibrillation. 1/3 of each group had been previously hospitalized for atrial fibrillation. So patients were randomized in a 1-to-1 ratio, stratified according to type of atrial fibrillation they had, and they all had an implantable loop recorder. So that was inserted at enrollment, and we assessed them for a minimum of 2 weeks to check a baseline AF burden. Patients then came to the catheter lab, and then under sedation were either randomized to pulmonary vein isolation using the Medtronic cryoablation system, or a sham procedure involving phrenic nerve pacing to simulate an ablation. Patients were followed up at 3 months and 6 months, and the first 3 months constituted the blanking period. The primary outcome measured was AF burden, and secondary outcomes included time to events, patient-reported outcome measures, including the AFEQ2 questionnaire, the MAFSI questionnaire, SF36, and ERS form. I think Dr. Veasey is going to go into some of the results that we saw.
Yeah, so the findings were in many ways as expected in terms of the primary endpoint. There was a substantial and significant reduction in AF burden in the intervention arm as compared with placebo for the cohort of patients overall, and also for the subsets of paroxysmal and persistent atrial fibrillation. We found similarly with our secondary endpoints that there were significant improvements in all of the quality of life measures, all of the questionnaires that we assess this for. When we were designing the study, we very much wanted to try and focus on symptoms, but the statistical analysis that we'd planned and looking at the sort of power calculations we needed, it was proving very challenging to work out exactly how many patients we would need for our symptoms as a primary outcome, because we had no measure of what sort of placebo effect may have on symptoms. So we had to design the study primarily around a hard endpoint of AF burden, which we already know that there's lots of data that suggests there's a correlation between AF burden in symptoms. So that was our primary endpoint. And then we made sure we had all the secondary measures of symptoms, which for lots of us is going to be a more interesting outcome of the study. And also perhaps pave the way for other ongoing studies and further studies. There are other groups that have got bigger cohorts of patients that are primarily looking at symptoms, and with our results, and we'll await the results of those studies with interest.
You know, it gets us into a little bit of the question about the limitations, which we'll get to in a minute here. But, you know, honestly, trials started in 2019. Most of the trials back then were focused on burden. It's only, you know, we've always known symptoms are important, of course, in AFib outcome assessments, but really it's only been the last couple of years that we've really called for symptoms as the primary outcome, as some of these studies over the last couple of years have revealed that maybe there's some importance to the 0.1% AF burden, and patients with some AFib recurrence within that burden constraint are still quite happy with their outcomes. I feel like that's been a more recent conversation, and it's easy to make hindsight, you know, criticisms, but like you said, burden is associated with quality of life and with symptoms, and I think it's a meaningful outpoint still.
Absolutely. We lost at least 18 months of this study, and we would have had results too, maybe even 3 years ago if it wasn't for the COVID-19 pandemic. We had to put the brakes on the study and completely abort recruitment. Some patients who had been enrolled into the study then had to leave and go back to standard care because of the turmoil and restrictions that we had at that time. So, as you say, it was envisaged in a time when studies were all about burden, would have been completed probably still in that era, or as we're transitioning to focusing on symptoms, and perhaps would have had a different conversation now.
Right.
So I would say, adding to that, obviously there's lots around that time we were looking at the data and data from previous studies showing correlation between AF burden and symptoms. And if you look at our study, and obviously the primary outcome is hugely significant, but if you look at all the secondary outcomes, every single one is substantially in favor of ablation. There actually isn't a secondary outcome which isn't positive. So it just gives further evidence showing that direct link between AF burden and symptoms.
And we talked to lots of electrophysiologists about this study, and half of them said, look, you don't need to do this study. As electrophysiologists, we know it works. We know it makes our patients better. But when you talk to our GP colleagues or our general cardiology colleagues, there's a reluctance to refer patients for AF ablation because, you know, it's seen as, yes, it might improve symptoms, but half of these patients are still in atrial fibrillation, and we've seen data that supports that as well. And so it's really a message to the EP community, yes, but to general cardiology, to our primary care colleagues, that we've got really good evidence that there's no substantial placebo effect in terms of the primary hard endpoint of getting rid of atrial fibrillation, but it also substantially makes a difference in terms of patient well-being and symptoms. I think that's clear-cut. And as we said earlier, there'll be other studies coming along. And and it'll be interesting to have more debate once we get further studies that have looked at these questions as well.
I was about to make a very similar comment. As EPs, we are quite familiar, we do the follow-up, we understand which patients are helped by ablation and to what extent. And so, looking at a study that shows that AFib ablation helps may not be earth-shattering to us, but as you said, a quick summary and an easy outcome to read for those who don't spend their days thinking about atrial fibrillation and the management strategies. It goes a long way, I think, to, kind of convey the way that we manage this and the modern way, which is ablation. Any other limitations that you feel we haven't mentioned that we should bring up about the study?
So I think one of the limitations is that we designed the study such that it only lasted 6 months. And that was intentional. So when we were designing the study, we did a lot of focus groups with patients. And we know from previous studies looking at ablation versus medical therapy that there's a lot of crossovers, which hinders the interpretations of results. And feedback that we got from patients that probably going beyond 6 months, you start getting withdrawals. And they were less likely to volunteer to go into the study. But saying that, the study focus was not on the long-term outcome of AF. It was purely to check if there's a placebo effect. And I think the study showed that there's no placebo effect at 6 months. Extremely unlikely that you're going to get a placebo effect at 12 months versus 6 months. Obviously, there might be a regression to the mean in some of the data in terms of AF burden and the symptoms. However, that will probably be due to disease progression and non-durable pulmonary vein isolation.
Right. We hinted a little bit at the significance of the trial in the AF ablation space, its ability to communicate to those outside of our field, and to, in very specific particulars, rule out placebo effect. How has this laid groundwork maybe for future studies? We talked about different outcomes, but we finally have a sham trial in the AF ablation space after watching our interventional colleagues do this for a number of years. What's the significance here, and what might it promote investigations in the future? Maybe Dr. Veasey will ask it.
Sure. I think we've got the reassurance that what we're doing is the right way forward. And I think as electrophysiologists, we really want to focus on who are the right patients to be ablating. Can we, work out who responds to ablation, who doesn't? And there's still a huge amount of work to do in terms of what are the strategies for catheter ablation. This study was a relatively simplistic approach. It was a pulmonary vein isolation with a cryo balloon. We didn't use other technologies, as we felt that was the easiest way that we ablate to replicate a sort of sham procedure. But I think as electrophysiologists, we can focus on what's the best technology to get durable pulmonary vein isolation long term? What are the additional region sets that we need to do, and for which patients, and which patients are going to get the maximal benefits from interventions that have quite considerable time and financial considerations. They also, they're operations not without risks for patients, albeit the serious risks are small, but it's still something to factor into decision-making processes.
Yeah, excellent. I've had a personally researched interest in the cardio-neuroablation space, and that is certainly a subject that could benefit from a sham trial. So I'm happy to see this results out there and fostering discussion amongst all of us. Well, congratulations to both of you, Drs. Dulai and Dr. Veasey. Congratulations on presenting the results of your study at ESC 2024 and for joining me today.
Thank you very much. It's our pleasure.
Yeah, thanks for having us.
This has been Breaking News with Heart Rhythm TV. I'm Clinton Thurber. We'll catch you next time.